Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Shirley, are there any written communications?
There are none.
Very good. We'll now move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar items A through E?
Yes, Mr. Vice President, I move that the Board of Directors approve the consent calendar items A through E.
Thank you.
Second.
We have a second. Shirley, could you take the vote?
Director Eapen, Director Wallace, Director Nicholson,
Aye.
Director Yee,
Aye.
and Director Stewart.
Aye.
Thank you.
Here, the consent calendar items are approved. All right. So, Tina, if you could introduce our presentation.
It's my pleasure to introduce Dr. Chet Morrison. Dr. Chet Morrison is the Trauma Medical Director for Washington Hospital. Prior to his joining our team in January 2024, he was an Associate Professor of Surgery at Central Michigan University School of Medicine and Trauma Medical Director for St. Mary's Ascension Hospital in Saginaw, Michigan. He comes to Washington Hospital with 23 years of trauma surgeon experience, being board certified in surgery and surgical critical care. He has authored multiple papers related to trauma and is also involved in leadership roles in several regional and national professional organizations, including ASPEN, the American College of Surgeons, the Society of Critical Care Medicine, and the American Association for Surgery of Trauma. And I did want to just let the board know that last week we did have our pre-site survey on April 30th. Leadership from both Alameda County and Santa Clara County EMS were here. In terms of that, they and our pre-site surveyors did interview staff, trauma leadership, reviewed protocols, did a site tour, and overall, we have a few refinements, but overall we got very positive feedback. And I'm sure Dr. Morrison's going to speak a little bit more about that, but I just wanted to give a little bit of a preview of that to the board.
Thank you, Tina.
Okay, thank you very much. Thank you to the board for having me tonight. So I'll give you a little update. But Tina just said everything, so I'll just sit down. Okay. No, actually, I did want to go over this in some detail because I actually think there's a lot of positive that we have to say. And frankly, well, there's two things. One, I'm eager to share it. And the second thing is, like everything else in trauma, actually what I'm going to summarize represents a lot of work by a lot of different people. Trauma is the quintessence of a team sport. And so we have a really good team. Just go over a little background, and I apologize in advance if this is very familiar to the board members, but just to make sure everybody's there, that in 2022, the decision was made by Alameda County Emergency that has been designated as the decision-making body to designate Washington Hospital as a Level 2 trauma center. And the reasons for that are fairly clear in a couple minutes, but the size of the county, the geographic distribution around the bay, made it a good idea to have another Level 2 trauma center here. It can take ambulances almost an hour at sometimes, particularly in California traffic, to get critically injured victims to closest trauma centers. That's above the golden hour. That's something, that's something actually that could actually affect outcomes And so it was thought that having one would actually be very beneficial to the people of the county, and I certainly don't think I need to say to the board, but I will say, just because I say it to myself, that this was something that the people of Alameda County made very clear that they wanted through their leadership and in many comments. So that's why we were honored to do this. The consultant engaged also agreed with us. There's also, the fact of the matter is that the population does grow with the population at large. There isn't a mass exodus of people out of California, no matter what you read the national media. Actually, the population's growing a little bit, so here we are. The other thing, of course, is that we thought it would have a positive impact on the trauma center, the 24/7, the partnerships, all those things that I think we're sort of familiar with that you could read on the board slide. One thing I can't resist adding is the last bullet about the halo effect for the entire hospital. I have already taken like an all of one, but still a one referral specifically to us from my colleague at UCS Benioff, who says he now has a patient who aged out of, his pediatric surgery care, and would we care to take care of her? Sure. She lives in the county, so bring on. So, I don't know what would happen, but it's nice to have those outreaches and all that. So I think the trauma halo effect is going to be real. And that's one of the reasons why we're so passionate about this. The other thing is, and I've shown this slide a lot, but one of the updates really is that, you see our slice of the turf. This sort of is like the southern portion of what I sometimes refer to, in my own mind at least, as the Bay Area Trauma Consortium or the Bay Area Trauma Cartel, depending on how I think about it. And like anything else, a cartel exists with a very stated purpose, and if everyone agrees there, it actually is a nice entity that can be very effective. What's happening is, if you look just to the southeast of our red dot, the regional medical center is closing. So, they're not going to be accepting trauma after the 1st, or, on August.
12th is
the 12th of August, not too long after we open up. And so you can kind of see the gap. Obviously Santa Clara County is going to want to keep as many patients in their county as possible, but just by geography, we're going to get some of them. And the other thing is, I mentioned earlier about California traffic. San Jose gets kind of cloggy sometimes, Santa Clara. So there's going to be time advantages to get it up. And although I don't know what the magnitude of it is, I think it's very clear from just, again, looking at the map, that it looks like we're going to be getting more patients than we might have originally thought. And that's the vibe I get from discussing this with the various members of EMS and the community and so forth. So that's that update geographically. But obviously, the concept of our Bay Area trauma cartel is still, I think, a very real one, and that's the way it's going to be going forward. And that's why I think, actually, I haven't been involved with this long, but even from my point, it's very clear that this was the window of opportunity for Washington to get into that consolidation and really be one of the pillars around that area. As we mentioned, we did have a change of leadership. And Ginger Miramontes, who's in on the call, is joining us as our interim trauma program director. We had actually been interviewing her for a while, and we're very, very fortunate that she has agreed to step up in the team. And the other one that is a very good addition to the team that we are also very fortunate is Jennifer Kubish, who came on board as our injury prevention coordinator and is very much working sort of hand in glove, as it were, with Ginger. And the position of trauma program director and manager and PI coordinator are very much the sort of NCOs on the field who actually get things done. I can say, I think we should have this, but they're the ones that actually kind of get it done. And not only that, they're the ones that have to reach out to everybody else in the department with their topic and coordinate everything so that our vision becomes a reality. So we're very happy to have them. We're hiring for registrars, and of course, none of this, including like the presentation, would be possible without the support of my fabulous executive assistant, Felisa Fullard, who, to this day, I remain grateful for having her because she's also very much with the mission and very much gets things done. So, because of this, I think we have a very good leadership position, and I also think you know, it's sort of a stable leadership going forward. All right.
We're all excited
with
to be
our time-
part of the team.
All righty, yeah. Okay. Well, it's an, you know, it's an opportunity for everybody. All the opportunities kind of, you know, came at the same time.
Room 28.
Okay. So, the heart of the presentation, in a sense, the heart of the presentation was this. As Tina mentioned, we did have our pre-site survey on the 30th with Alameda County and Santa Clara County personnel, their directors were both there, as well as an outside trauma medical director and trauma program manager who also surveyed us, who were, you know, so who were very good to make contact with the outreach, and also, by the way, who are also very experienced and really knew their job. So obviously, we very much listened to what they said, but as sort of mentally part of this, they were actually very helpful in terms of giving us positive feedback about what we were doing well and what we still need to do, and you know, some pointers about getting there. And you know, they feel the trauma system is well on its way. They think that we're well positioned to be open on the 1st of July. And you know, again, it was a nice thing to tell Santa Clara. And really, the overall theme is that walking around there, it's like, yeah, we're serious about doing this, but we're prepared to make the investment and actually, you know, do what it takes to be there. And that was very much the message that they got. So I was happy. On this part of the slide, of course, you can see our timeline. I'll have it. I'll have it in the next several slides. But also, as you can see, this on the left of the one, in the second quarter of 2024, we've done that. We have done the ALCO application, the pre-review questions. Those were also put in last month, and we did our survey. So on the 5th, which is also sort of in the left part of that timeline, we have our official site survey, which is, again, Alameda County. I just heard that Santa Clara County is going to be part of that one, too. It's going to be brilliant, yeah. The crowd is probably not going to shrink. It's probably going to grow. And, you know, I embrace that, because what we're trying to do is we're trying to show everybody, now that we've made some steps, and that we're someone that the county can feel good about, saying that, okay, we're going to designate you provisionally as the trauma center, which means we are now going to start bringing the critically injured to your doors, as well as to the other members of the consortium. And we get provisionally designated. And if the survey June 5th goes as well as the one on 30th, I actually think we have a very, very high chance of success. Okay? I mean, you know, obviously, as I said in my comment before, the county wants us to succeed. Everybody wants to succeed. We have to do our part. But it's very supportive there, because everybody's saying, good, we succeed. We want you there. All right. We have a ribbon-cutting ceremony planned on June 24th now. We want, that's going to be participation and publicity, and I've seen the address list and a variety of, and we want, you know, state and local and yeah, everybody to come, and that'll be a big deal. And of course, it all, you know, kind of comes to the point on the July opening of the Washington Hospital to incoming trauma patients. You know, we're not going to, we're just going to open our doors and start, after all this hoopla, we're going to open our doors and just start taking care of trauma patients. That's what we're going to do. Okay, got it. That's the vision. Okay, in July 2025, we are actually starting the verification preparation, and part of that is that they're going to actually start looking at patient records and patient charts, and that's what starts because we have a consultative review on the roughly going to be on the 2026, February, I think. And then, you know, in spring 2027, as part of the 3-year cycle, and I just remind everybody that the ACS has determined that they're going to survey and approve the county centers as a bunch. Now we're in that bunch. And so, you know, that's going to be an interesting time. And but I also think that with the proper attention that we've shown so far, that we'll get it. And then after that, if we're successful in our verification review, that the Alameda County Emergency Medicine Service will now formally designate us as a Level 2 trauma center. And we stay that way as long as we continue to be certified by the ACS. All right.
How often is that survey
It's
maintained?
every 3 years. That's actually the best outcome. If there's deficiencies, they sometimes say, we'll come back in every 2 weeks. Yeah. So it's a little bit like when JACO comes by. Ideally, you want them to say, good, everything is great, we'll see you in 3 years. Sometimes they say, we're going to come back in a year. And actually, to be honest, when I was at my previous hospital, they discovered something and they said, we'll tell you what, a couple of deficiencies, they said, we'll tell you what, if you can actually provide documentation to us within the next 6 months, we will not come back in a year, we'll give you 3 years. But you had to do it. It had to do with the number of registrars we had, things that were fixable. So we basically fixed it. We sent them the documentation and said, okay, and they didn't bother us for another 3 years. So I imagine that's what's going to happen here. Particularly, as I said, because it's a consortium with all the other members of the cartel of the county, but the trauma centers here is a bunch. All right. It's a little perhaps obscure, but the title of this slide was Additional Medical Staff Strength Capabilities. About the people joining our team, we're expecting our second trauma surgeon to start in June, part of the opening. And he's someone we've been communicating with, and he knows where we are at this journey. We've established trauma coverage relationship with the UCSF group of orthopedic surgeons, a real turnkey practice in that they were this group that was providing care at regional. Impressive, actually, in terms of what they can offer us, they're sort of like the Cadillac, and that obviously, it's not a comparison to our other providers and everything, but they showed us that they could give an impressive range of services, such that I personally am very comfortable with them covering the orthopedic aspect of trauma. There's an increased FTA in hires for the hospitalist service, and one of the liaisons is a geriatric liaison, but our geriatric liaison, as interim and vice director of our hospitalist group, is also very invested in trauma. And we said basically, like with everybody else, the work's going to go up, but we appreciate in advance all that you're going to do. And so we have someone that will actually help us with all the medical care of our trauma patients. We're hiring for expanded anesthesia coverage. That's another department that had to be plussed up, which we're doing because we're now going to have the anesthesia coverage in-house that will handle trauma and obstetrics, which is good because then it's an automatic backup with the call space for them. And that gets us to our infill process, which is coming up. I think probably most members of the board are familiar with the timeline, but I thought I would give it up, especially because showing the county our infill process and what we have planned for our Morris-Hyman Pavilion was actually kind of part of April 30th, and we advanced it a little bit because that's going to be the ultimate solutions to the things that they'll see, and they'll perhaps raise their eyebrows a little bit in terms of what patient flow is and what we can do. So, for example, they said, well, you have to go that 150 yards or so forth from the Morris-Hyman where we have the ED patients to the main hospital, where our ORs are. Oh, and of course, when the operations are finished, we then have to go back across there, but again, we say, yes, but that's temporary because here's our plan. Here's our infill, and frankly, the nice thing about that is it's going to be done by the time the ACS rolls in. It'll be well done. So then it'll be new and gleaming, and actually that's one part of the verification I kind of look forward to. See our nice new infill thing? And this is the plans. Again, everybody's familiar with them, but it brings up a couple topics. One, because as I said, we're no longer going to have to do the oscillation back and forth between ED or critical care units. The other thing is the MRI is going to be there. And frankly, as it stands right now, the MRI is an issue. And that's just the way it is. I mean, we have an MRI that was built essentially was built for outpatients. It's very nice for outpatients. It's lovely. You go in, it's very, very, very nice, peaceful, very love. But, for the needs of the trauma and the critical care patient, it's not really where it's at, to be blunt. And so they know this. And so we have a plan. This is our long-term plan. People are never going to leave this building. to get an MRI. They're going to be right there. And they're going to be 2 floors down from the unit, from the floor down from the ED. The other thing, however, is that we have to have an interim plan beyond what we have to get us there. And I'll be talking to it a little bit, but we need that interim MRI as well, because they can forgive us for like the 150-yard dash under a roof to get to the OR. And going across the street to the MRI, they're going to look and saw as outpatient, that's a little harder for them to swallow. So actually, in point of fact, they know of our infill plan, they know of our contingency plan for mobile MRI, and we actually even had to give them an MRA safety plan, a formal document of how we're going to make it so that our trauma patients are safe while we're getting them across the street. And by the way, the vibe was, that was some of one of the things, it's like, you better have that by having
sure.
So,
Yeah.
and that's just the way, and that's just the reality. Anyway, we have launched our new geriatric fracture protocol, which is also something, because that ties into the way we take care of the geriatric trauma patient, which every trauma center gets quite a few of. And part of that is expediting times of surgery, older patients with orthopedic fractures. And again, I have to say that at this point now, I have very good partners in orthopedics, nursing, and sound medical physicians, and the medical staff there. So I feel quite confident in that. We're having our PIPS meetings now. We had our second PIPS meeting. They're the 4th Wednesday of the month, and we still don't have patients yet to discuss it because we haven't opened it. But we have processed things, and we actually are reviewing cases in the hospital. They're not activations yet, but the hospital has a very busy ED, as we know, and they take patients, and sometimes the injured patients show up, or they're taken here because they have airway issues, and we actually looked at those. So we have our process improvement in patient safety well underway, and we're going to continue that. We're continuing to work on our templates and order sets, and actually the past few days, that's actually a lot of what I've been doing, and that's coming up there. We actually have, it's actually nice, because some of the other trauma centers have reached out and say, oh, this is the way we did it. Oh, would you like to see our protocol? So great, and they're all evidence-based. They all come from, recommendations of the bodies, some of which I'm a member, like AAST and so forth, all the basically the gurus who come with recommendations, and so they're very evidence-based. And, the other thing that was nice is we set up a session where we started with all the little aspects of it, like getting the equipment done, getting the orders actually through, and getting, getting everybody together for our performance improvement and all those kind of details that come in. So we now have a committee, and it was actually a very pleasant surprise when I was at the last trauma operations with Ginger and with Sarah Stillwell about how well advanced actually it is. Under the surface of that, actually a lot of work had actually gone on, which frankly put my mind at rest. We still continue our educational outreach in our nurses in ED training, TNCC, TCAR. We've got our MDs taking ATLS. We got their numbers. We had a successful effort where my colleagues in surgery got to go and do a big didactic trauma acute care surgery course. Get that plussed up. They're very happy about that. Enthusiastic attendance because it was held in Las Vegas. But having been there and see the curriculum, it's actually very, very valuable learning experience. I'm doing a grand rounds next week, so there's internal hospital education as well. And of course, we continue to do our outreach. Our external marketing campaign is going well. Jerry, our public director, and Angus are doing fabulous work. We had a choking prevention event in Niles, and that actually was quite well turned out. It was good. I met actually some Fremont notables there, so it was a good event for me to go to. Our Stop Bleed campaign continues, and we have a fall risk prevention as well. Local future participation, we hope to, I mentioned the grand rounds, and that's going to be something that'll be recurring. And it's actually, the grand rounds are a good format to do in-hospital physician education, because we can do those. There's the local conferences that we're going to be a part of, as well as the ECAA that we're going to be participating in. And the other priority, the last slide I want to just do is priorities. The mobile MRI on the left of the slide is sort of a very broad hint. That's how we're going to solve our situation there. And, I have to emphasize that that's actually going to be very necessary as a part of it. Because we've already sort of promised we have a solution to the patients who need MRI. We are going to continue with our hip fracture and geriatric trauma, and the thing that the next goals really are basically care coordination, discharge planning, and acute rehabilitation. Hiring a physiatrist, getting our ARU. One of the barriers to really cost-effective care in that population is placement and good throughput that's consistent with care. So we're still working on that. Our pediatric readiness is going well. Our Alco pediatric survey did great, and we have a good collaboration, as well as transfer agreements now that have been written with our UCS and colleagues, who again have been very helpful and supportive in reaching out to us. I already talked about MRI, so I don't need to go over that again. And, again, I think ultimately one of the things that will have a halo effect and really kind of make us a serious player is that acute rehabilitation. That's impressive if we get that off. Okay. So it's basically, that's in what I think is an overview and sort of the latest of where we're at right now. And so this is the part of the presentation I take questions.
Judy, Bernie?
This is good stuff. Really, really impressive. Thank you.
Well, thank you very much, sir.
We've been through some hard times here for a while.
Okay.
And this is really uplifting, fun, tremendous service to the community and to the expanded community. I was really excited that you've had
Santa Clara.
Santa Clara, yeah.
Yeah,
They're
that's
going to be.
wonderful.
Yeah.
That's really, really a powerful move. Thank you
Well,
for what you're doing.
that would sort of fell into our lap in a sense. But that's kind of the way it is. And one of the things that really diffuses my, animation and zeal is this is really an opportunity for everybody. It's an opportunity for me personally. It's an opportunity for the hospital leadership. It's an opportunity for the community. Because as the trauma centers consolidate, things come here, and that really will make Washington Hospital, we're really going to be a Bay Area player now.
Yeah, welcome to Ginger and Jennifer.
Yeah.
Hey, guys.
Right.
Yeah, thank you, Dr. Morrison. I definitely wanted to welcome Ginger and Jennifer to the team, and I know the team will be well served by Felice's expert administrative assistant. I think you're very, very fortunate to have her. So, Dr. Morrison, I have just two questions. One, you did talk about the golden hour. Can you just go over a little bit about why that is so important and what actually happens during that golden hour?
Well, the golden hour was a concept that came about as trauma centers were being formulated, because the thought process is that when patients are critically injured, you have a short window of time frame where your interventions can be meaningful. So in that hour, you can stop bleeding, start resuscitation, and when a lot of patients, if they can survive that hour and you can actually get them to stop bleeding, will do fine. It's when you get outside that golden hour, and there's some debate about, is it really an hour, is it more, parts of it an hour, like everything with trauma, it's, complicated. But the basic concept is the same. The sooner you intervene in these folks, the better they're going to do. So if you intervene within the hour and stop them, they actually do better than if you intervene in the second hour, by which time their shock has increased, they're a little colder, they've been in a little more pain, and they don't do as well, and they're going to take longer to recover. And then, further on, your survival drops. So the whole concept was to get people within this hour, which again, no matter what the debate is for whether it's 59 minutes or 61 minutes, it's all about rapid diagnosis and stabilization and getting them on their way to being fixed. And one of the things that I kind of sometimes say this to the residents there is like, being a trauma surgeon, doing trauma is like one of the few things that you can do that's very well paid, that actually rewards in patients. Most high-level positions, you actually kind of have to be patient. but being trauma, I actually get to be inpatient. I kind of want the pictures now. I want to get the patients now. I want to get them to the operating room now, or as practicable. Time is not your ally. So that's why they have it. The original concept obviously came from Cowley, and in some of the presentations I've gone into the history of trauma centers and why he did it. But that's why he does that. And the other thing is, your other point there, when patients come in the pre-hospital and the trauma bay, our response is to a large extent scripted, because over the years we've worked out a nice set of priorities that so we have those priorities because they efficiently allow us to tell what's wrong with folks, to intervene on the most life-threatening things first. So
speed is of the essence.
Speed is of the essence. As I say, you don't need, it's not like we need to do drama, shouting at people, oh my God, it's not like the ambulances need to break speed limits and put themselves in jeopardy. But we get to be kind of impatient too.
Yeah.
Kind of want it.
But part of that is a highly functioning team, and so that's why I'm very glad we have experienced people as part of the team to be able to develop these services. So speed is of the essence. One thing I saw on your slide, looking at the section of Alameda County that were designated, it's big. It's big. So how often are patients helicoptered in from trauma that might occur out? It will happen. I don't know how often it's going to happen, but I anticipate it's going to be in the double figures per year. I'm looking at 20 to 30 per year. And but I came up with that was we actually had a meeting with the Stanford Aerovac team. That came in. We actually used our helipad, and they landed in it. We said, oh, this is very nice. We promised, we're going to plus it up. It's going to paint it and everything. And one of the things we specifically said is about, now we have the ability to get patients farther. And they said, oh, it's not even that. They pointed to the hills. They pointed to Mission Peak. They said, periodically people injure themselves just mountain biking or four-wheeling on Mission Peak. And they said, if you're in the line of sight, we're going to take you there. And I said, well, bring them on. This is what we're doing. We're open for business. So what I'm getting at is actually I anticipate that probably 2 or 3 patients a month are actually going to come in by helicopter. Maybe that's a little, maybe that's a little optimistic, but they have assured me it's going to happen. Yeah, but part of success is being prepared when opportunity comes. So that certainly happened with the Santa Clara Regional Medical Center issue. And obviously we are well prepared with our Morris Hyman Pavilion and our helipad and the infill space, all of these other things which are going to, I think, contribute to a very successful trauma program. So we look forward to the ribbon cutting, but more importantly, we look forward to July the 1st when we start accepting patients. So thank you very much.
All right.
Okay.
Thank you, Dr. Morrison.
Thank you.
Thank you, guys.
Okay, we'll now move on to our medical staff report. Is Dr. Soleil with us, Ray? Is he?
Hi, I am here. Sorry, just unmuting myself. Good evening, everybody.
Oh, there we are. Okay, good.
Sorry about that. Well, that's a hard act to follow. Dr. Morrison's presentations are always very intriguing and very interesting. So for my report, just a census of the medical staff, we have 344 active staff. Out of that, we have 624 staff total. Out of that, 344 are active medical staff. The rest are distributed among administrative, advanced practice providers, ambulatory, consulting, courtesy, leave of absence, as well as several provisional categories and temporary privileges. In terms of medical staff news, we have the next general medical staff meeting is the beginning of June, I believe, June 11. So we're in preparation for that already and getting things on the agenda. Ongoing preparation for trauma. In my role as chief of staff, as well as the medical director of urology, in discussions with Larry, with administration, the other urologist, Dr. Morrison, preparing for the on-call panel, and all the things that need to be in place for July 1st. The other thing that everybody is now excited about is the robot, the Da Vinci robot that is going to be coming to the hospital in the next week or so. I met with the reps today, as well as I've been in touch with the urologists, getting them excited about it, asking them to get their privileges in place for the ones that are already doing it elsewhere, and then the ones that don't and may be interested, we're going to see if we can help them get some training and get them on board as well. The goal would be to increase the overall surgical volume here. Instead of converting cases that we already have, we'd like to bring in cases that are coming from outside, whether it's robotic prostatectomies or other renal surgeries. We know at least one or two of the urologists, for example, are doing cases at other hospitals, and Dr. Shu is doing them over at Stanford Valley Care Hospital. So we would hopefully get the program going soon and bring all those cases on board here. The final thing is the Beta Heart program. That is the very important program that we have to address any complications, to deal with the complication itself, deal with the family especially, in terms of helping them along, supporting them with any issues that may come up, and risk mitigation. Several people, doctors and administration staff went to a meeting just last week, I believe it was, right? Possibly the week before that. And they're being held on a regular basis. Any questions about any of that?
No, I think I just wanted to express our appreciation to all the hard work that the medical staff is doing on all of these very important initiatives, and especially with bringing in all the new staff to help support our trauma program. So thank you very much, Dr. Saleh. Appreciate it.
You're welcome. My pleasure.
Keep up the good work.
Thank you.
Okay, you too. All right.
Take care.
All right. Service League report. Sheila, there you are. Oh, you're muted. You're muted. You got to unmute, or maybe Sri will unmute you.
Okay.
There we go. There she is. Ah.
You kind of threw me off, Dr. Nicholson. I looked for Dr. Epen, so you kind of threw me off there.
Oh.
So.
I think he's kind of a ways away.
Well, good evening to all of you.
I hope I'm a satisfactory substitute.
You are
Maybe not quite as.
Yeah, well, anybody who talks Portia is very satisfactory to me, and Shakespeare is my favorite. So there you go.
Thank you. Thank you.
Good evening to all of you. Extend a warm greetings from all the volunteers. I'm pleased to report that for the month of May, 585 Service League volunteers collectively contributed a total of 1,595 hours to the hospital. On April 19th, we hosted a successful high school information session, which was attended by over 40 enthusiastic high school students. The session provided valuable insights into the various roles and responsibilities of volunteers within our hospital, igniting a passion, I hope, for Service League among the next generation. Additionally, we recently held a new volunteer orientation on May 4th, which saw a turnout of 33 individuals. The orientation provided comprehensive information about our hospital's mission, values, and various volunteer programs, ensuring that our new recruits are well equipped to make a meaningful impact. Regrettably, the masquerade sale that was scheduled for April 29th, 30th, and May 1st had to be postponed due to unforeseen circumstances. However, we are excited to announce that the sale has been rescheduled and will now take place at the end of July on 29th, 30th, and 31st. And we really sincerely appreciate your support towards the success of this important fundraiser. Today, I'm honored to shine the spotlight on one of our most beloved volunteers, Fran Stone. Fran's steadfast dedication to Washington Hospital has been truly remarkable. Her contributions have left an indelible mark, and she was recently honored by Assembly Member Alex Lee at the Unsung Heroes event for her outstanding 45 years of service to the hospital. This award celebrates the contributions and positive impact of individuals in our community. Fran's impact extends far beyond her impressive tenure. Her tireless efforts in founding the hospital gift shop and spearheading the Top Hat Gala have significantly enriched our hospital. What sets her apart is not just her length of service, but her ongoing commitment to volunteering. Despite her many years of service, we can still see her at the volunteer office, tirelessly contributing her time and skills to making baby bonnets with the Magic Hankies group. Fran Stone's dedication to the true spirit of service inspires us all to strive for greatness. And I'd like to express my gratitude to volunteers like Fran Stone, whose commitment and passion continue to make a lasting difference in the lives of others. That's the end of my presentation. Please let me know if you have any questions.
Thank you, Sheila. Yes, we're indeed very fortunate to have Fran serve for so many years and in such a valuable way. So yeah, she represents part of the heart and soul of this institution.
Yes, she's been our go-to person for everything that's passed. Any questions we have, we email her, call her, talk to her. She's just wonderful.
Tremendous resource to have her.
Yes.
And I'm really encouraged to hear that you had 33 new volunteers at your orientation session. So I think that's a wonderful thing, both for our community and for them as well.
Absolutely, absolutely. Thank you, Dr. Nicholson.
I'd just like to add something on Fran Stone. At the recent golf tournament, she spent the entire day out on the course with us at Wackaduck.
Bless her heart.
That's impressive.
That's truly remarkable that she has the enthusiasm to do it. You know, she's done it for 45 years. She can put her feet up and relax, but nope, she keeps going like the Energizer battery.
Thank you, Sheila. I really appreciate all of your work.
Thank you.
Okay, now we'll move on to our quality report, and Mary Bowron is going to give us the quality dashboard for quarter ending March 2024.
Thank you, Dr. Nicholson. So as you stated, this will be the quality dashboard that reflects the first 3 months of this year, so January, February, and March. And we'll start off with our infection prevention indicators. First one is MRSA, and it's a bacteria that is in the blood that's very difficult to treat with antibiotics. It's resistant, methicillin resistant. And unfortunately, we did have 2 cases this quarter, and that is the second quarter in a row that we've had more than expected. And so we've been working really closely with our infectious disease consultants and Dr. Martin, especially working with antimicrobial stewardship and the nursing staff to look at ways that we can prevent MRSA from getting in from a patient's skin and into their blood. And one of the things that we're doing is implementing new order sets for antiseptics like chlorhexidine and things to prevent the patient from bringing this bacteria on their skin into their blood. So we've taken those seriously, done root cause analysis, and that will be our action plan moving forward. On our next slide, for catheter-associated urinary tract infections, this is, again, another great outcome to report. We are actually, as of now, 407 days without a CAUTI. So that is a really good sustained outcome for a nursing sensitive indicator such as this. And it really is a reflection that we're only putting in catheters in patients when they're medically necessary, and when they are, we're taking excellent care of them. And this is a combination of a lot of disciplines working together to make sure that patients' catheters are maintained well, even when they're ambulating or in bed, and that the nursing staff has done a great job for caring for these catheters while they're in place. So remarkable outcome. One of the things to remember with these type of outcomes is that it's bad enough what patients are coming into the hospital and they're dealing with their acute illness, and the last thing we want them to have to do is deal with a hospital-associated infection. So when you sustain rates like this for months and quarters on end, it's really a reflection of decreasing patients' overall risk for being sicker, even mortality risk, all of that. So it's not just that they don't have a cavity, it's that we also, and those lead to a lot of improvements overall with the quality of their care, rather than having to deal with a hospital-associated infection while you're in the hospital. Very similar, great results on our next slide for CLABSI, which is a central line associated bloodstream infection. This is actually even a greater sustained outcome, and very much similar along the lines of what we see in CAUTI, but for a longer length of time. In about 9 days, we will be at 2 years without a CLABSI infection. Huge success. I just can't say enough for the safety of the safe care and good quality care that these patients are getting when they have to have a central line in place. And of course, it's an invasive line, and so it's very important that they're placed carefully with using a sterile procedure. And then when they have to be in place, that we are maintaining very strict care of the line and the dressings. And again, when you have an outcome that sustained this long, you can feel very comfortable with the safe and quality care that the nurses, medical staff, and all disciplines are providing for these patients who are already sick because they have to have a central line. So great job to the team working on that. And then we're moving into our surgical site infections. As I had mentioned in the last quarters, we're really sustaining this one also with our colon surgeries are a higher risk for patients developing surgical site infections, which is why the federal organization of CMS has us monitor these patients for infections. And again, for this quarter, we have had 0 surgical site infections related to our colon surgeries, and very well sustained. And it's a reflection of how safe our ORs are, how clean they are, the aseptic technique that the staff is using in their education we give our patients when they leave to prevent getting surgical site infections. So overall, great work. You'll see the same as we move into our hysterectomies, which is another surgical site infection that we monitor per regulations from the federal government. And we have sustained great outcomes here for now our 6th quarter in a row without a surgical site infection in abdominal hysterectomies. And it's also a reflection of the things that I mentioned with the colon surgery. So great job to the OR team and surgeons. C. diff is also a very difficult bug to treat in patients, and we have had this last quarter 0 C. diff infections, which I'm happy to report. Our last one was actually 12/31/2023, but so far this year, calendar date, we have not had any. So that's less than is expected for a hospital of our size and type. You typically would see more about 7 infections, and again, we had 0. This is something that we've worked on for years, and as you can see, it's been sustaining for an excessive period of time, far less than expected infections. And we have very strict algorithms that we work with the that are approved by the medical staff on which patients we test, how we treat, how do we use our antibiotics, and we're very strict on our antibiotic use here. And antibiotic use is appropriate when necessary, but one of the risk factors is, of course, that you can develop C. diff. So we use those with great stewardship and things like hand hygiene and using our testing algorithms, making sure we're collecting the right type of stool to send to the lab. Lots of disciplines are involved in this. Great outcome, again, of just having 0 infections this quarter. Hand hygiene is a national patient safety goal. And this is, I think, the highest compliance I've seen for hand hygiene here so far, and we're at 94%. And this is fantastic because it exceeds our local, our national guidelines. Even the World Health Organization sets a benchmark at 70%, because that's how difficult and challenging it is to get people to wash their hands at the right time and place, and we're at 94%. And we've had a lot of different areas and disciplines working on this. And our patient safety team has made this a priority. They work very closely with infection control. And this quarter, we started implementing some new training methodologies, et cetera, and we have more people. But you'll see even moving forward, even after March, when I come back here with this next report, we're going to even have more success to report with this because we've implemented an electronic monitoring device and for monitoring hand hygiene on the unit level. And so we're collecting way more of observations. That's not reflected here because we didn't start it until April. But the good news is what we've seen so far since we've started it since April, that we've been able to sustain this. And like I said, we have a very strict process for how these hand hygiene observations occur. I feel very confident in the data collection, even more so that we're using and improving technology, and 94% is good. Preventing, the best way to prevent the spread of infections is through hand hygiene. So 94% probably has a lot to do with the other prior outcomes you've seen so far. Moving into more nursing sensitive indicators, starting off with our injury for falls per 1,000 patient days. We are far below the national benchmark for this, where we did have, this is a reflection of just one fall. And that puts us at a 0.06. The latest benchmark that we have from NDNQI, which is our national database for nursing on falls, is about 0.58. So there's very little tolerance on this, and that's right and appropriate. We have a lot of safety mechanisms that we put in place to prevent falls. This one incident actually was very atypical in the fact that this patient was not identified as high risk for falls, was not a high risk for falls. They were just getting back on a gurney and slipped and fell and just had a very minor injury with some pain to the wrist. So a good also reflection of a safe environment here at Washington Hospital. We assess all patients for fall risk. We put them closer to their nursing station if they are at fall risk. We do a lot of rounding. All disciplines are responsible for monitoring for fall risk, and again, sustained for a very excessive period of time, now 6 quarters in a row under the benchmark. We'll see similar when we get into our hospital-acquired pressure ulcers, otherwise known as bed sores. This is another metric where we observe a certain number of patients over a certain period of time, and these patients are randomly selected. And out of this quarter, there were 102 patients surveyed, and we did not have a single stage 2 pressure ulcer. So again, that puts us below the benchmark. We're at a rate of 0.9%, 98%, 0.98%, and the national rate is closer to 1.53%. Again, very low in order to meet your benchmark, so we're even further below that. And this team who goes about and does these, what we call a point prevalence survey, takes it very seriously and documents and looks very carefully and dedicates themselves to only that assignment on that day. So again, to find 102 patients without it is great quality care. Then we're moving into our readmissions. Overall, for this quarter, we did fairly well in some areas of readmissions, and we continue to have to focus on the other ones. Starting with our heart attack patients who came in and had a heart attack, we did have 24 of those in this quarter, and 4 of those patients did come back. And that does put us at a higher rate than the federal government of CMS expects. That puts us at 16.7%. National benchmark is 14%. And so for these 4 patients that came back, we do a root cause analysis on each one. We have new leadership, and we're building a really solid, good team in transitional care. And they're looking at these cases all individually. They're working with our readmissions champion, Dr. Aurora, who is a intensivist here also at the hospital. And what they have found with these cases, there were 3 of them that actually came back from a skilled nursing facility. And so 3 of the 4. And we're working very closely. We've done some on-site visits to our skilled nursing facilities, especially the ones that we have higher volume with and that we have in our high quality network. We had a lot of good discussion with them here in the last month and talked a lot about communication, observing patients as they begin to have complications and trying to see what sort of bundle implementations we can help and work with the SNF and partner with them so that patients don't decline to the extent where they need to come back for acute care. We are very careful at Washington Hospital that if a patient shows up in our ER and of course meets for an admission, they're coming back. So these patients were actually sick enough to meet to be inpatient. But again, we want to focus on doing prevention tactics with the community to prevent the patients having an unnecessary back to the acute care. And then moving into our pneumonia. Pneumonia has been historically an area that we've had a lot of challenges. So I'm happy to report that we're in our third quarter in a row of having less than expected. We had 82 patients who came in with primary pneumonia, and 9 of those patients over the quarter did return. Gives us a readmission rate of 11%, lower than CMS national benchmark of 16.9%. And then moving into heart failure, another chronic illness that we've had challenges with as far as readmissions go. We did have 50 of those patients this quarter, 12 of which came back. And that puts us at 24%, which is about 4% higher than what CMS would expect. But these patients were here for an average of 4.5 days, and that was what was expected for them. And so it's not that the patients were prematurely discharged. We did have half of those patients, half of the 12, actually left with assistance. It was either a skilled nursing facility or home health. So we took the same approach with these 12 cases that I mentioned with the patients with AMI, or otherwise known as heart attack, and really working closely with the SNFs and also working with our home health agencies to make sure that the patients are being monitored carefully and getting the care that they need in their home so that they can avoid having to come back and have an unplanned readmission to acute care. So we'll continue to do those sort of things with heart failure. It is a difficult illness to manage. These patients were actually very sick, these 12 patients. Dr. Aurora and everybody has reviewed all of them. All of them met for medical necessity to come back. And so again, we're looking at ways of improving medication management and direct observation of the patients and making sure they really have the support that they need and understand what they need to do to manage their chronic condition after they've been discharged from the hospital. Because a lot of it is that, and making sure that they get the right support. And if they don't have family members or don't have a primary care, we're trying to set them up and sort of break those fragmented areas of risk to the patient. And then moving into COPD, another very difficult chronic illness to manage. We did have 20 of those patients this quarter, but 3 of those 20 came back. It gives us 15%. It is lower than CMS expects. So they expect around 19% of these patients to come back. This is one, as you can tell, the numbers are small, but it does go up and down. So we're trying to apply the same thing with this COPD population as the other populations that I've mentioned. While I'm very pleased it was below the benchmark this quarter, it's just still too up and down. We're recognizing that this is still a high risk group for us and applying the same transitional care interventions that I've already mentioned. And then getting into our surgical patient population for readmissions, patients who came here and had a coronary artery bypass graft, otherwise known as a CABG. This number looks a little bit skewed because this slide only shows you what fits into CMS's criteria for CABG that they look at. So it's a primary CABG, Medicare patient only. And so for this quarter, there's only one of them. And unfortunately, that patient did come back. And that patient did go to a skilled nursing facility and then had to come back from the skilled nursing facility. They were not prematurely discharged. They were here for the expected length of time. Again, working with the SNF to see, this is sort of an outlier case. I mean, the patient really had some further issues with their heart rate and shortness of breath and needed to come back. And I don't really think there were any lessons learned that we could have worked with in the SNF. It's just sort of a complication on that one case. But then we have another slide that shows you the other CABG cases that we did this quarter, the other 10. And this would be looking at all the payer sources outside of Medicare. And we did have one of those patients come back, but that puts us at 10% and just slightly under the benchmark for what would be expected, about 11% for this. And same thing, patient fully met medical necessity and did need to be admitted back. And our next surgical population group is looking at our patients who come in for an elective primary total hip or a total knee. And again, these are inpatients. It is very much the standard now to do this procedure as an outpatient, and that's where the majority of ours go. But some patients are at higher risk because they have chronic illness or they have a lot of pain management issues, hypertension, diabetes, and we need to put them in inpatient. And that is for a small portion of the patients. In this quarter, it was only 15 patients that needed to be inpatient. And very happy to report that none of those patients, even though they are sicker and were inpatient, none of those patients came back. And again, that's a great outcome for the fifth quarter in a row in a patient population that is at higher risk for getting readmitted. So 0% there. Also a good reflection of great care in the OR. We have a huge team that works very closely with this, as it's our largest volume surgical patient population, and they're doing a great job, obviously. And then I just wanted to show you lastly, the group of patients that are outpatient that come in and have hips and knees replaced. And that volume, as you see, is much larger. It's 344 patients for this first quarter, and only 4 of those patients came back to be readmitted. We do take those 4 seriously and do follow a similar process that I mentioned with our medical cases, where transitional care looks at them, Dr. Aurora looks at them, we work, and these go through peer review and go to the surgical team for review. But overall, still very low, 1.2%, and the national benchmark is 4.3%. So just great work considering the number of patients, 344 that had that procedure. And that concludes my report, and I'm happy to answer any questions.
Thank you, Mary. Jeannie, any questions?
Overall, remarkable report.
Thank you.
Really outstanding. What a wonderful thing.
A lot of good teamwork.
I think we ought to advertise this.
This report was
Yes, Mary, the biggest challenge of having such impressive results, as you know, is sustaining those impressive results. And as you see, we have issues that pop up here and there, but as you look at a longer baseline or a more expansive denominator, the numbers remain impressive, even though you might have things which appear to be an outlier. So I'm very happy with what is being done to continue to improve the quality of care here at this institution. I know we've got some work again to do with MRSA, and I trust that will happen. And the thing I'm especially impressed with, because it does require so much work on behalf of the nursing staff, is our extremely low fall rate. So that is a remarkable achievement, and I think we should recognize our nurses for making that happen. That's a very important thing.
There's so many things that put a patient at risk for a fall when they come to the hospital, because as you know, with all the medications, they're in a new place, an unfamiliar environment. Most of them are elderly and who are in this risk category. So it's exactly as you say, when you see it that low, that means that they are consistently following all the national safety standards to keep patients from falling. It's very impressive, and as impressive as Clapsy and County. And you're right, we're absolutely focusing on sustaining these is our next best effort to focus on.
Yeah, I think the fall rate is just one facet which reflects the excellence in our nursing care here.
I would agree. Absolutely.
Thank you, Mary.
Thank you.
you.
Okay, we'll now go on to finance report. Tom.
The fun I'm happy to share March's final operational and financial performance numbers. Inpatient, average daily census at 169.1, about 3.3 under budget of 172.4. Combined average daily census was 178.4 on a budget of 182, or just shy at 3.6 under budget. Our discharges for the month of March were 908 on a budget of 1,097, so off about 189, and we are off about 638 on a year-to-date basis. Our patient days were 5,241 on a budget of 5,345 for a difference of 104. Outpatient observation equivalent days were favorable at 287 to a budget of 289. We trail on a year-to-date basis by 564 days. Our average length of stay beat budget at 5.14 on a budget of 5.23. On a year-to-date basis, we still are slightly over at 11 basis points. Our case mix index, stronger than budget at 1.567 versus a budget of 1.517, or about 5 basis points. And we are stronger on a year-to-date basis by 3 basis points at 1.579 versus a budget of 1.547. Deliveries for the month of March at 134, just shy of the budget at 143, off 9, and on a year-to-date basis, trail budget by 12. Surgical cases outperformed at 476 versus a budget of 468, while cath lab cases were behind budget by 27 at 186 versus a budget of 213. Our outpatient days exceeded budget by 145 at 8756 versus a budget of 8611. Emergency visits at 5,162 were 50 greater than budget at 5112. Surgical and cath lab statistics. You can see the 476 and 468 breakdown for the actual and the budget. You'll notice the two large areas with large variances were orthopedic and vascular. Certain joint replacements are moving to Washington Outpatient Surgery Center, and that's reflected in that number. And then the other, on the vascular side, Dr. Wu departed the organization, and so some of those numbers are dampened. In the cath lab, you can see 186 versus 213, and the large one here is the non-vascular IR. Other operating indicators on the productive FTEs. Productive FTEs were favorable to budget at 1,438 versus a budget of 1,564. Excuse me, 126 better, while non-productive FTEs were actually 57 over budget. Necessarily a good thing. FTEs per adjusted occupied bed at 5.75 versus a budget of 6.28 were 53 basis points better. And on a year-to-date basis, we are 31 basis points better at 598 versus 6.29. So getting into the financial numbers, actual gross income for the month of March was $213,237,000 on a budget of $211.8 million for a variance of $1.4 million. Contractuals exceeded our budget of 74.33, coming in at 75.38, or just over 100 basis points different. While the provision for bad debt came in under, that's the second time in this fiscal year that it's actually come under our budget. And so all in, total deductions were about $2.4 million higher than what we budgeted, and contractuals and total deductions came in at 76.78 on a budget of 76. Looking at the compact income statement now, you can see the numbers from before. So I'll draw us to line 5, which is the net operating income. Net operating income for the month of March was $2.16 million on a budget of $3.2 million, so off about $1 million. On a year-to-date basis, we are still behind budget by $14.3 million on net operating income. Drawing you to the bottom of the page for non-operating income and net income, the non-op income for the month of March was $1,029,000 on a budget of $64,000. And on a year-to-date basis, non-operating income is $10.9 on a budget of $3, or strong outperformance by almost $8 million. Net income for the month of March was $3.2 million on a budget of almost just over $3.2 million. And on a year-to-date basis, our net income is positive at 5.5. However, we trailed budget by $6.4 million. On a FASB side, you can see the numbers are reflecting a little softer performance given the exclusions that GASB allows in their income statement and FASB does not. And so we look at the net operating income again, the fifth line down, you can see instead of 2.15, it's 1.5. And you can see that we trail on a year-to-date basis by $15.5 million. Down at the bottom, same thing in the non-op section. There's an exclusion for FASB, an unrealized loss on investments and net interest on the GO bonds. We're not able to include for FASB, so our net income is $2.5 million on a budget of $3, making it a negative number year-to-date instead of positive $5 million. So we trail by 10.2. Okay, EBITDA. So again, we're on line 5. EBITDA for the month of March was $5.5 million on a budget of $6.2. So we trailed by $717,000. EBITDA on a year-to-date basis is $24.1 million on a budget of $36.7. So we're trailing by about $12.6 million. However, the EBITDA margin has strengthened. Point out that month of March, the EBITDA margin was 10.8 on a budget of 11.9, and on year-to-date, we're at 5.6 on a budget of 8.3. And with that, concluded March's report.
For the finance, any questions? If you could go on with April,
Okay.
hospital operations.
I'll now cover the preliminary April report. Total gross revenue for the month of April was $194.5 million, which was favorable to budget by $2.3 million. Budget was at $192.1. For the year, gross charges are at $2.02 on a budget of $2.021. So we're very close on a gross basis to being on budget from gross charges. On the inpatient side, gross revenue was $112.4, which was unfavorable by $6.4 million, though it is $13.1 million higher than last April.
Mm-hmm.
On the outpatient side, gross revenue was favorable by 8.7 at 82.1 versus a budget of 73.34. Key operating statistics, our average length of stay for the month of April was 6.22 on a budget of 5.18, so that's unfavorable. As we looked at this, there was one patient who had 196 days. They were in for a disease, and then that had some serious complications. However, that patient left us, I think late last week or early this week. Then we had another one just over 100 days, and they were transitioned to a hospital in Taiwan.
Mm-hmm. As far as,
And that-
do you have any data as far as excluding those two outliers?
Including those two, thank you.
Just trying to cue you up here.
It's 5.9 without those two.
Okay, all right.
So still high.
Still higher than
where we
than budget, yeah.
especially against budget.
Mhm.
Outpatient observation days were at 279 versus a budget of 256. Inpatient average daily census came in at 151.7 on a budget of 163.3, or off by 11.6. And the combined average daily census of 161 is unfavorable to the budget of 171.8. Discharges for the month of April, 825 on a budget of 869, so off 44. However, 33 higher than last April. And then while we don't have a slide for this, admissions came in at 786 for the month of April, and on a budget of 869, or off 83. Patient day trends. Patient days came in at 4,551, which was unfavorable to the budget of 4,900 by 349 days. So I will point out it was 309 days higher than last week on patient days. And where we saw the biggest shortfall in days is adult med surg was off by 430. Surgical trend. Total surgeries in the month of April were 465, 16 short of budget at 481, though 44 more than in April of 23. Again, I will point out that some of that shortfall relates to certain ortho cases moving over to the surgery center, which you can see in the surgical activity. Ortho was off 24 at 172 versus a budget of 196. Neuro, 23 on a budget of 28. And then vascular surgery, 36 on a budget of 40. Cath lab trend, we are right on budget. 196 on a budget of 196.
That should garner a
Well, then you're going to love this. Inpatient cases were off by 9 from budget at 98 versus 107. And outpatient cases were 98 over by 9 from their budget of 89. So off by 9 and over by 9. And the cath lab activity here on the next slide. Cardiac cases, over by 25. As you know, Dr. Agarwal is doing more heart cases, and especially in the cath lab, so a number of those cases are attributable to Dr. Agarwal and Dr. Lin. Karen. Deliveries. Deliveries came in for month of April at 114 on a budget of 120, so off by 6. C-sections were 39, or 34.2% of total deliveries, which was 5% over budget, 500 basis points, in other words, at a budget of 29.2. And it was essentially the same as the prior month. Non-emergency department outpatient trends, 9,068 on a budget of 7,820, so 1,248 was the outperformance there. Imaging services were favorable to budget. 1,200 to budget. by 451. Cardiac rehab were favorable to budget by 256. And lab visits were 211 favorable to budget. That's a big turnaround in the lab.
Yes, yes.
So, emergency department visits, 4991 versus a budget of 4501, with roughly 70% of the visits at level 3 or lower. Financially, on a gross revenue basis, the 194.4 million breaks down as surgical services at $31.8 million on a budget of $39.9, so a shortfall there. Cath lab, just under at 10.8 versus a budget of 11.3. Room and board came in at 40.6 on a budget of 42.2. Birthing center came in at 3.1 on a budget of 3.2. Emergency department, 13.4 on a budget of 11.7. And ancillary services, as we talked about just a second ago, the lab and imaging and the infusion, came in at 94.9 on a budget of 83.9 for about $11 million to the upside. So on the payer mix, we saw some additional softening from the prior month in March. March was about 54.4, 54.3 in the Medicare. We're now at 55.5 on the Medicare side. Medi-Cal stayed roughly the same at 20.6, so under budget. That's a favorable to us. But the government payers came in at 76.1 on a budget of 72.2. HMO came in higher than budget at 2.6. DPO, however, came in 520 basis points under budget at 18.9 on a budget of 24.1. The revenue cycle team, finance, and leadership are taking a deep dive into the PPO decreases that we've seen since the beginning of the year. On a year-to-date basis, though, we're still averaging 22.7. Private pay went higher at 2.4 versus a budget of 1.4. There were total of 2.1 million in charges from out-of-country patients in April, and there were 6 accounts with charges exceeding 100,000 for a total of 1.5 million. So, productivity. Productive FTEs were unfavorable to budget by 27, while non-productive FTEs were slightly favorable by 4 on the non-productive side. Total FTEs per adjusted occupied bed of 6.22 were unfavorable to the budget of 6.1 and worse than the prior year of 6.18. So, this is really getting our flexing and managing our overtime and double time, which is reflected in the 6.22. Okay, WICMIF. The clinics were unfavorable to budget by 3,397 on 1,688 versus a budget of 19.5 million, or 1,000, excuse me. Be great. This is due to 6 open positions of 700, accounting for the 733 days. Then there were leave of absence, extended leave of absence, accounting for another block of that, and then unexpected time off, exceeding what was budgeted. Having said that, primary care visits, and I should mention that even though we were off budget, we're still 2,600 more than last April on the total visits for WIC. And then of the primary care physicians that are there, 4 are relatively new, hired in the last 6 months or so, and they're still ramping up their practice. And then I mentioned the 4 that were on extended LOA. On specialty care, open positions in psychiatry, vascular PA, et cetera, accounting for about 200 of those days. And then general surgery, and then Dr. Wu's departure. Radiation oncology for the month of April, 273 treatments on a budget of 472. As Kimberly and others have talked about in the past, the treatments, the regime has tightened up. It's shorter. You don't need as many treatments now, and that's one thing. And then we are talking about doing some outreach to non-system physicians for referrals, doing some outreach on referrals and marketing, and then looking at growing certain areas of the cancer treatment areas, like prostate or something like that. Tina, did you want to add anything to that?
No, you covered it. I mean, again, I think that Dr. Yoshida gave a presentation to the board in terms of how the treatment protocols are changing in terms of less treatments per course of treatment for a patient. And then, as Tom talked about, we are doing some strategic planning with UCSF, with the joint venture, in terms of looking at ways to grow market share.
Do you think we should change the dashboard which is presented with respect to rock and have it more reflective of?
Yeah, exactly what you said. Within the fiscal year, we're going to change
Okay.
indicators that will be presented.
Thank you.
More reflective.
Extremely good program. Looks like we could make some real headway in promoting that.
Absolutely.
So-
And again, the partnership, right, with UCSF is important, and so we are looking in terms of
I'd be remiss if I didn't mention that 30 new patients referred, with 9 higher than prior years. 19 new treatment starts, which was 0.6 lower than last year, so pretty tight. And then 23 new patients seen in clinic, which were 2 patients less than the fiscal 23 average. Okay, preliminary outpatient on DevCo, 2,201 on a budget of 2,251. And with most of the shortfall here at the rehab, Washington outpatient. WASC was favorable by 104 cases to budget, and PSC was favorable by 17 cases for the month to budget. And then in keeping with the old adage, always end on a high note, financial statistics, days cash on hand, we finished at 152, a 22-day increase from March.
How high that was compared clear back to April of 23.
Right. And there was 328,000 in charity. The increase in days is due to the rate range and quit funds. We received our second payment from both of those. They split the payment in half, so we got half in March and half in April. So that's where you saw the 120 go to 130, and now, and then we had 4.7 million come in from the foundation. So this is the largest amount provided in a single check. So we're very excited, and the foundation is very excited about that. And then we got a $1.2 million increase in our investment portfolio for the month of April, and we had $1.2 million less in
So this will all be reflected on the financials that are presented next month.
So this will all be presented, and we'll share with you.
Okay.
Great. And that concludes my report.
Great, thank you. Any questions for Tom? I like the high note. Very good. So we'll go on to the hospital calendar.
Sure. I'd like to start with the Employee of the Month for May. So Kathy Kesey began her career in the tech industry and worked 30 years at a semiconductor company. Her duties included working as part of the safety teams and dealing with the unique personalities of engineers. Kathy laughingly says that both of these experiences helped her prepare for work in healthcare. In 2010, when it was time for a career change, Kathy became a certified nursing assistant. And on the advice of a former nurse manager, Alice Santos, she began volunteering in the emergency department at Washington Hospital. Kathy's volunteer duties were in addition to working in registration, so when the opportunity to work full-time in the ED arose, Kathy was prepared to accept. Kathy enjoyed the fast pace of the emergency department and being part of that team. However, after 10 years, she was ready to make a change. And in 2022, the Wellness Center was transitioning out of COVID and needed someone special in the concierge role. Kathy was that person. According to her manager, Kayla Gupta, Kathy's ability to manage the schedules of the multiple massage therapists and fitness instructors is second to her exceptional customer service. Kayla says she is a cherished member of the wellness team. Kathy has earned the affection and respect of colleagues and patrons. She understands and lives our patient-first ethic. Away from work, Kathy appreciates time with her family and beloved pets. Born and raised in Fremont, Kathy enjoys spending time with her 96-year-old mom and her partner and best friend of more than 20 years. She loves going on outdoor adventures and can be found zooming around town on her motorcycle and enjoying time away in Tahoe. Kathy has a strong passion for environmental conservation and animal welfare. Her contributions to our wellness center and to our organization are valued, along with her ability to find humor in challenging circumstances. Congratulations, Kathy, our main employee of the month. So I'll go on, if you're okay, on the rest of the report. So I'm going to move on to our past health promotions and community outreach events. So on April 13th, we hosted a partnership with Second Chance with our tattoo removal program, and that was held in Washington West, and 31 people were served. On April 17th, we had Grief and Grieving with J.B. Goodyear, our spiritual care coordinator, and that was at Carlton Senior Living Community with 16 residents attended. And on April 20th, with the City of Fremont, we hosted Go Green with Us in 2024, our Earth Day celebration. And that was held at the Fremont Downtown Event Center, and there were 500 community interactions, 2 large containers of sharps collected, and 3 tons of paper shredded. Very good, yep. And then on April 24th, we had Dr. Alexander Saw, who talked about robotic knee surgery and muscle-sparing anterior hip surgery. And that was held here in Anderson Auditorium. We had 24 who attended in person. We had 83 live views, and then 174 people viewed it after it was done. On April 26th, we had our volunteer appreciation luncheon in Washington West, and 100 volunteers attended. And on April 27th, the Medical Foundation hosted a booth at New Haven Day at James Logan High School, and we had 100 community interactions. And then on April 30th, Dr. Argawal, our interventional cardiologist with the Medical Foundation, did a presentation, Heart Valve Disorders in Adults, at Acacia Creek in Masonic Home Senior Living, and 26 residents attended. And then on May 6th, we hosted Healthcare System Week, Wellness and Benefit Expo. So that was right here at the Moore Simon Critical Care Pavilion Atrium. And then on May 7th, we had Dr. Jack Rose, Stroke Prevention Awareness, and Facebook Live and YouTube. The next, this is just giving you some pictures. This was the grief presentation at Carlton on April 17th. And the next is the Go Green Earth Day on April 20th. This is some great pictures from our volunteer appreciation luncheon on April 26th. New Haven Day, April 27th. The Heart Valve presentation with Dr. Argawal at Acacia Creek on April 30th. And our upcoming health promotion and community outreach events include Healthcare System Week, also Hospital Week. We're calling it Healthcare System Week to be inclusive of the whole healthcare system. And we will be hosting that with a variety of events and recognitions for our staff. On May 11th, we'll be hosting Spot Me Free skin cancer screening at Nakamura Clinic. And on May 14th, we will be doing a choking first aid with Betty Goodwin in our ED department, and that's going to be held in Anderson Auditorium. And then on May 14th, we have Larry Asio with PT on Let's Move, Staying Active as You Age at Acacia Creek and Masonic Home Senior Living Communities. And then on May 16th, we will be hosting Bike to Work Day Energizer Station outside Washington West. And then on May 16th, we will be doing Celebration of Life in Anderson Auditorium. And on June 6th, Dr. Bryant Balmer, our orthopedic surgeon, is going to be doing a presentation on updated treatment for hip pain and arthritis. And that's going to be on Facebook Live and YouTube. And then June 10th, we'll be hosting Fremont Debate Academy in Anderson Auditorium.
Oh, that'll be interesting.
And then we have the Healthcare Foundation. So we hosted the 37th Annual Golf and Bocce Tournament on May 2nd. That was at Castlewood. We had 120 golfers and 28 bocce players who joined. It was a great day of friendly competition, and the event raised funds for equipment in the hospital's operating room and trauma center. We also had the quarterly trustee meeting on April 23rd, which the foundation presented a check, which Tom talked about. That was for $4.7 million in support of the wide range of clinical services at the hospital, and that included $4.5 million from the UCSF Cancer Center. So I do want to thank all the generous donors. We very much appreciate in terms of making that record-breaking contribution possible. And then the foundation has begun planning for the 38th Annual Top Hat Gala. That's going to be held on October 12th. And a visioning session was held actually today to solicit input from community members. So they are going to start meeting monthly and starting on May 21st. So planning is underway for Top Hats. We also have pictures of the from the golf tournament, from the foundation golf tournament. Cheese in there.
Yeah, young golfers.
We also have here our healthcare system quality incentive pool performance award. So it's my pleasure to share with you that the healthcare system received top performance award for our quality incentive pool program. This award is given by the California Department of Healthcare Services to hospitals that meet targets linked to quality outcomes for care delivered to Medi-Cal members. We are the only district hospital to receive an award for top performance 2 years in a row. And I do want to thank the physician leaders, the medical foundation, the quality teams, IT, a number of people who were involved in terms of this outstanding achievement. So congratulations. And then I'd be remiss, I know we talked about Fran already, but we wanted to definitely share a picture of Fran. I know Sheila talked about it in terms of already her Unsung Hero Award given by Assemblymember Alex Lee, and I also wanted to express congratulations to Fran on behalf of the healthcare system.
Absolutely.
She's been just wonderful over the years in terms of her commitment to this organization. So. And then we also have the Board of Directors report in terms of attending on April 13th, Assemblymember Alex Lee's Unsung Hero Award ceremony. Also on April 19th, the Fremont Leadership Prayer Breakfast. And on April 27th, the HERS Breast Cancer Foundation People with a Purpose Gala.
Very good. Thank you, Tina. So we have a singular action item, and I know the board is very pleased to be able to entertain this action item. Tina, could you give us some background introduction?
Sure, absolutely. So as you know, we've been in negotiations with the California Nurses Association in terms of their agreement. Well, we did reach a tentative agreement on a new 4-year contract starting July 1st, 2023. This was ratified by their union or by their membership this past Friday on May 3rd, 2024. So I know there's a memo here, but I wanted to just cover a few of the highlights from that contract or that tentative agreement. So there is a 22.5% across-the-board wage increase over 4 years. 5.5% year one, 5.75% year two, 5.75% year three, and 5.5% year four. It is retroactive pay of 5.5% back to September 1st of 2023. There's also increases in hourly differentials for evening shifts, night shift, nurse relief, and nurse preceptor role. They also, included in here is the implementation of the new health plan as of July 1st. And there will be a change of uniform color from white to navy blue with a one-time $100 stipend. And then maintenance of the current contract language on floating and life areas for floating. There's a number of other contract changes as it relates to some of the language, but those are essentially the highlights from that agreement, or that tentative agreement.
Thank you, Tina. I think we're all very pleased that the issue is to this point. So, Jeannie, if you could present a motion.
My pleasure. I move that the Board of Directors authorize the Chief Executive Officer to proceed with entering into a contract with the California Nurses Association agreement.
Thank you. Thank you. We have a motion and a second. Shirley, could we have a call vote?
Director Eapen, Director Wallace, Director Nicholson,
Aye.
Director Yee,
Aye.
and Director Stewart.
Aye.
Thank you.
Wonderful. Motion passes. Resolution 1261 is affirmed. So we're glad to have taken care of. Any announcements? No announcements. Well, there being no further business before this board tonight, the meeting is adjourned. Great. Enjoy the month.